Welcome back to the 12 Days in March video podcast edition. This material was delivered during a series of live lectures at the University of Massachusetts Medical School. In this edition, we will focus on gout for the USMLE Step One exam. As with all presentations, a PDF of this recording is available at the 12 Days website. And as a reminder, 12 Days is now offering tutorial services. For anyone interested, please check the website for details.
So enough on osteoarthritis, but I was able to squeeze a little garbage out of that with the antibiotics and the septic joint. Gout figures big on the boards. This is, if they're going to ask, this is going to be the focus. So you have to be familiar about how they're going to present. Pain, swelling, redness, check. Most gout questions, they do stick a needle in it, but you have to know that it's not uric acid, it's monosodium urate crystals. You know it's gout because they can give you, again, that inflammatory infiltrate with 50% PMNs, but there's no bugs. Your main differential diagnosis for gout is going to be pseudo-gout, and on a pseudo-gout versus gout, they have to give you the crystals or give an X-ray with the classic findings of pseudo-gout or classic findings of gout. So they have to distinguish it. And compared to septic arthritis, they have to give you a gram stain, they have to give purulence on the synovial fluid. So this inflamed joint almost always comes attached to some synovial fluid analysis. They ask derivative questions about tophi, and that's a tophus. And tophus is just one of those things where you're going to go in an exam room one day and someone's going to stick their joint out and they're going to say, "What's this?" And you say, "Well, I've never seen one, but that's a tophus." Because you know what a tophus looks like? A tophus. There's nothing else. It's like fascinating, but that's what it looks like. And again, there's no mistaking a tophus, but what they're going to ask you is, like, they'll describe the gout patient, they'll describe them having this nodular thing, and they're going to give you, what's in there, monosodium urate, but there won't be any description of these palisading histiocytes as seen with a rheumatoid nodule. So it's not that they're confusing, but just be familiar with the description of a gouty tophus compared to a rheumatoid nodule. X-ray again. So here's, just like with the tophus, I'm not like Joe Radiology or anything, but so this is a guy who's a retired New England Patriot, in fact, and he actually came in with tophi. And by the way, who gets tophi in this day and age are people with renal failure or renal insufficiency. So they all have hyperuricemia, they can't excrete uric acid, and they may not be having acute gout attacks, they're just hyperuricemic and it starts depositing. Those are the people who get these tophi. So the tophi is a soft tissue swelling, and you don't have to worry about that, you can't really see it. So tophus is different than the joint erosion. The joint erosion, this rat-bitten, I beg your pardon, rodent-bitten, I spent too much time looking up whether it's a mouse or a rat, so I couldn't, mouse-bitten or rat-bitten. Do you guys have any preference? So just knowing about these punched-out, overhanging edges, you just hear about it, and the first X-ray you get, you pull it up, and it's like, oh my God, that's it, you got gout. So be familiar with the description of these punched out or overhanging edges. And again, the issue is going to be compare and contrast with rheumatoid arthritis when it comes to the radiographic descriptions. All right, so we said all this stuff, acute mono, the majority of mono, but you can have polyarticular involvement, recurrent episodes. Once you had your first one, it's just a matter of time till the next one. Foot is most common. It used to be when I started in this racket, all the gout questions were in the feet and the knee questions were pseudo-gout. Now they mix and match, so you just have to pay attention to what they're telling you. Could be the foot. They can do other joints with gout. You already know about monosodium urate crystals. And so they're taken up by white cells and all hell breaks loose. So this is, again, neutrophilic arthropathy. This is that classic drawing with that little gremlin, and somewhere along the line is like, what's podagra? We say, oh, you got podagra, the big toe. Pod is foot, agra, catching or seizure. So it's a seizure of your big toe. So that makes sense to me. Now I know what podagra is and I can deal with it. So the big toe is classic, and they'll give you that, true swelling, redness, severe pain. There won't be any confusion about that on the boards. The differential, the bottom line is, it's not that there are crystals there, absence of bugs, that's big. Hyperuricemia, these patients may have high uric acid, but it has nothing to do with the diagnosis. You got to see crystals in the fluid. Uric acid level we get to track therapy, basically. So you have a uric acid of 9, here's allopurinol. I want to get your uric acid down to like 5 or 6. They don't ask you that degree of specificity. As a matter of fact, I don't ever see them even talk about uric acid. They only talk about monosodium urate. And then, of course, they'll talk about treatment. And here's the differential. I can't emphasize enough, they will give you synovial fluid analysis, and here's your main differential, septic versus pseudogout versus gout. I don't know why I don't have it on here. Seronegative spondyloarthropathies also present with acute joint swelling. So the majority of people with gout actually are hypoexcretors. We're just not getting rid of uric acid. That is the majority. And, lead toxicity, alcohol, we see gout, and people use too much alcohol as a precipitant. The overproduction is only the minority, and where they're going to do it, it's disproportionately represented on the boards because they'll always link it to the issue of tumor lysis syndrome. Okay, and they won't ask you is it overproduction versus hypoexcretion, but the reason I'm mentioning the hypoexcretion, again, the kidney is the player here, is for two reasons. Number one is thiazides. So we know that thiazides cause hyperuricemia, and they can precipitate gout, just like niacin does it as well. And they compete for these organic anion transporters in the renal tubules. It never dawned on me how thiazides actually work in the kidney. They get pumped into the tubular lumen. That's how they ultimately block those pumps. Okay, so it has to get pumped essentially into the urine to work, and it just competes for the same transporter as uric acid. That's how thiazides cause hyperuricemia and gout. So here's the other issue. Nobody uses probenecid. It's kind of the digoxin of gout, but it makes for great, kind of pathways, mechanism of action stuff, right? So we already said the main issue with gout is we can't excrete it. Why not use probenecid? And it is truly a uric drug. It inhibits that exchange pump, so the uric acid, once it's in the tubular lumen, doesn't get reabsorbed. So it stays in the lumen. That's how it works. So the problem here is if you have low GFR, it doesn't work. It doesn't work in tumor lysis. It's just not sufficient. Contraindicated if you have uric acid stones, right? So I already said you're not reabsorbing uric acid. So when they are starting to lay out options for treatment of gout, prevention, this would be prevention, not acute. One of the things they may tell you is a patient has, they say they have a radiolucent kidney stone. All right, so and that's all. They'll give you a radiolucent stone and say, what drug would you use? Well, you won't use probenecid. So the probenecid is less about using, more so than when you wouldn't use it. So you need GFR, you can't have uric acid stones. So who would you use it on? Maybe a young hypoexcretor without contraindication. You'll never see that one. So probenecid is about when not to use it, not when to use it, and you will see it in the Q banks, and it's still fodder for the boards. All right, so this is, again, this was one of the drivers why I thought it was important to include gout. It really has a lot to do with treatment. So we're talking about acute, and look what I wrote, that means not preventative. So you have to know the acute treatments. Non-steroidals, COX-2 inhibitors, colchicine. Prednisone will never be a treatment. You'll never have to choose that on the boards. We do use it when people can't take other things. The way you'll sort out the treatments are, again, it's by contraindications. So they'll give you a patient who had hives or has an ulcer, bleeding ulcer 3 months ago, and now they have gout. What are you going to treat them with? Not non-steroidals. Okay, sulfa allergy. They love sulfa allergy as that contraindication to COX-2, celecoxib. So you got to look for the contraindications. That's the only way you'll get to the indicated treatment. And where I think that you guys will struggle again is just knowing the names of the different anti-inflammatories. On one of the questions, what did I give you? Piroxicam. I gave you piroxicam. I just want you to have diclofenac, ketorolac on your list too. Indomethacin technically is the non-steroidal of choice, but any anti-inflammatory would suffice. So NSAIDs are treatment of choice for sure. You can use a COX-2 if there's a contraindication, but you have to be familiar with colchicine. Colchicine is alive and well. We absolutely use it for gout. It's treatment of choice for acute pseudogout. Colchicine, the way they'll do it, they won't say, hey, use colchicine. They're going to describe it by leukocyte motility and cytoskeleton microtubules, all righty? So it's an anti-inflammatory, so not an analgesic, not a uricosuric, anti-inflammatory, decreased leukocyte motility. They'll say which drug works by inhibiting leukocyte motility. So you need to know that description, and here's their other favorite. Cytoskeleton functions are disrupted through inhibition of microtubule polymerization. That's the language of colchicine, and that's how they'll describe it. Okay? And then what they do is say, look, a patient was given a drug for their acute red toe, right? So they still didn't even say what it was. And the drug inhibits cytoskeletal functions or microtubule polymerization. And then they'll say choose the most likely side effect. It's really diarrhea. The flip side they'll give you is patient was given a drug to treat their gout. They developed diarrhea. What's the mechanism of action? That's how they play the game. It's an easy game. You know the rules, so you can play it too. So colchicine is big in the gout world. So that's acute. Those are acute. When someone has an acute attack, don't ever pick any of these, all right? When they say, how are you going to treat this acute symptom, it's these. How are you going to prevent this? How are you going to prevent them, right? Xanthine oxidase inhibitors, check. You guys are good with allopurinol, fluvoxostat. Probenecid we just talked about. And the sneaky one that's, starting to permeate into the boards now are the uricase drugs, pegloticase and rasburicase. All right, and really these are people who failed xanthine oxidase, have contraindication like hives. You might use it there. When I say treatment alternative for tumor-lysis, they're going to say, yeah, patient has AML, is going to start chemotherapy, and you want to prevent the joint outcome. What drug are you going to? Hydration, alkalinization, and they'll give you a drug. And they're not going to give you both xanthine oxidase inhibitor and a uricase agent. It's going to be one or the other. And so what happens is you're going to be looking for the allopurinol, but it's not going to be there because they're going to give you one of the others. So just be familiar with the full range of preventive treatment options. The majority of the preventative treatment is actually coming up, I see, under tumor lysis syndrome. And just know where on the pathway they can give you this whole cockamamie purine metabolism pathway, and point is like they were given a drug that works here. What drug was it? Allopurinol, xanthine oxidase inhibitor. All righty, so we have inflammatory, non-inflammatory crystals. And we have questions apparently. Alrighty, so first of all, what's the diagnosis? Yeah, swelling of the wrist. So look at that. They did it in the wrist, not the big toe, because they do that now, and fluids that negative birefringent crystals. And the question is immediate treatment. Is this about preventative therapy or acute therapy? It's acute therapy, right? So, and they're telling you she's got this sulfa allergy, so when they do that, that's on purpose, so you don't take celecoxib, right? That's what they do. So you're really left, what's acute treatment for gout? Which of these are for acute treatment? It's colchicine. Codeine we don't use. Aspirin at high dose, at anti-inflammatory doses, actually is a hyperuricemic agent. It impairs uric acid excretion, so you have elevated uric acid at high dose aspirin, not low dose. Allopurinol is preventative therapy, and acetaminophen is nice for pain, but this is an inflammatory condition. You need to use an anti-inflammatory medicine. Are people clear on this? All right, this is a busy question, I know that. I just have to tell you, like, everybody got this one, and on the previous question, only like 30% got it. It doesn't make any sense. You guys got smart in like 30 seconds. All right, so recurrent episodes of it. Recurrent disease includes juxta-articular erosion, overhanging edging. So what diagnosis is it? Right, that's a description of gout. It's not a trick question. That's how they'll do it. Okay, so that's where you have to be familiar. You don't have to look at an x-ray, but you have to know how they might describe it. So on a gout question, do they give you peptic ulcer disease? What drug aren't you choosing? A non-steroidal. Take that. You can do the strike-through on that one. There's your radiolucent nephrolithiasis, so that's a contraindication to probenecid. You can do a strike-through on that one. Allergies, hives on agent that inhibits conversion of hypoxanthine to xanthine. Obviously, they would never do that, but they will talk in some other bizarre language. So that's your contraindication to allopurinol, or they didn't give you allopurinol, they gave you the other one, fluvoxostat, because that may not be as fresh on your brain. So the sulfa contraindication is goodbye to Celebrex. The GFR, what do you guys make of the GFR? Has low GFR. That's just more reason to take the probenecid off the list, and it's probably a reason you shouldn't really be using the indomethacin either. So really, like gold, prednisone, methotrexate don't have a role in the patient with gout. If you thought that this was rheumatoid arthritis instead, you might have chosen one of those. So this is, they're going with something different. They're going with uricase. And, basically everyone got it, but this is such an extreme example about how they do contraindication language in the pharmacology questions.
And that concludes this discussion of gout for the USMLE Step One exam. If you have any questions or concerns, please email me at 12days. Thank you.